Good afternoon. Welcome to the March CDI Innovation Webinar. Before we get started, I want to go through a few housekeeping items. We are utilizing the On24 webinar platform. It's a web-based platform, so there's no dial-in number. If you're experiencing any audio issues, check your settings and also do a quick refresh of your browser, and that should clear up any issues that you're having. There are several engagement tools that you can use today to contact our presenters. The media player has a closed captioning should you need it. Check out the resources section where you can find today's presentation, a certificate of attendance. We do not offer CEUs, but if you use this certificate to request CEUs from an accredited association. We encourage you to ask questions. Please add those to the Q&A section. Today's session is being recorded and will be available on our website in the next few weeks. If you're interested in learning more about our solutions, let us know in the contact tool and we will get back to you. And lastly, let us know how we did by completing the survey at the end of the webinar. And with that, I will pass it over to Dr. Travis Bias, Medical Director of Clinician Productivity Solutions.
Cool, thank you very much, Bree, appreciate it. My name is Travis Bias. I'm a family medicine physician and Deputy Chief Medical Officer of our Health Information Systems business here at Solventum. And HIS has a few key strategic pillars, one of which is to create time to care. And so within that pillar, we leverage a lot of different technologies such as front-end speech recognition, ambient clinical documentation, and computer-assisted physician documentation tools to try to use technology to really just improve the experience for clinicians while they're capturing their documentation and capturing the complexity of their patient populations as efficiently as possible. And so you're going to hear a lot about what Dr. Anderson and team have done at Intermountain around this, but I think one thing to be listening to as he talks through this case study and as we talk about some of the outcomes that they've achieved, really we need to be thinking about, we are in the vendor space and the technology space, creating technologies not for the sake of creating technology, but to really make sure that we are solving key problems and helping clinicians do what they're actually wanting to do with this technology. And so I'm hopeful that what you'll hear is we're not just using AI because it's the hot thing in the last couple of years. We are using AI, we're using technologies, and we're using different resources at our disposal to make sure that we're targeting problems for clinicians to free them up to actually focus on their patients. And so with that, I'll actually hand it over to Dr. Anderson to start talking through a little bit about what Intermountain has done with such technologies and hear a little bit about the outcomes that they've achieved. So with that, I'll hand it over to Dr. Anderson. I will allow you to do the proper introduction of yourself, Dr. Anderson.
Perfect. Thanks, Travis. So Corey Anderson, I'm a hospitalist clinically by background. I've been with Intermountain Health for about 17 years now. And I think just a little bit of background, I serve currently as the Senior Medical Director for the enterprise for our physician advisor team, our hospital CDI team, and our hospital quality teams. And I've been in that role for about 5 years now. I think as we have these conversations, it's always helpful to kind of have some context and background, just because if you've seen one healthcare organization, as the saying goes, you've seen one healthcare organization. And so I think understanding where we come from makes it somewhat hopefully helpful to understand how some of the things we have learned may be or maybe not truly applicable to where you are at in your documentation, innovation sort of journey. Intermountain Health has undergone some changes over the last few years, and that is relevant as I talk about some of the work that we've done. Our legacy organization was a 24-hospital organization, primarily based in Idaho, Utah, and Nevada, that has facilities anywhere from a Trauma 1 academic medical center to multiple critical access, small rural facilities across the enterprise. We also have a full children's hospital as part of that legacy organization. That legacy organization is on one EHR and uses currently one type of CDI technology for our documentation improvement and some of the other efforts that we use to try to improve and enhance the experience for our providers. About 2 years ago, we merged with SCL Health, which is based out of Colorado and Montana, and added 8 additional hospitals to our organization. They are on a different EHR, and they are using some of the same technology, but not all of the technology. I say that just to be able to frame that primarily what I'll be talking about is that legacy Intermountain organization, or those 24 hospitals, because we're in the throes of trying to integrate those other 8 hospitals into the framework and the model that we've leveraged in the legacy Intermountain side. So again, the way I think structure matters when you talk about these things, and Travis has heard me talk about this a lot over the years. I think technology is great. It is a fantastic tool, but it is not the only tool in our tool belt. It is not the only way that we can expect quick results, or the way to fix some of maybe the gaps or the opportunities that we identify or exist within our organizations. Structure and people and workflows also matter greatly, and I think technology then comes in to enhance and to augment what those things can provide. Within Intermountain, we have what's called it used to be called the Office of Patient Experience. We actually now call it Clinical Excellence. And as you can see, this is the structure where the physician advisor team and the CDI team live, which I help to lead. And I show this because I think it matters. You can see that we're in the same umbrella structure as our quality team, as our patient advocacy team, as our clinical data team. And the reason I think that that's important is it means that we have broken down, I think, in a lot of ways, some of the silos that can exist in organizations, and we're bringing those different departments together to talk about this work, so that when we talk about what does documentation do for quality, the quality team is already there at the table with us, and we're having that conversation together. And we're aligned in what the tools can do to help us and help our providers and help our patients have a better experience and ultimately get the results and the outcomes that we want. And so I do think it's helpful to look at how are we aligned structurally, some of these teams, how many silos do we have to go and navigate, or are we already at the table with the right key stakeholders, which I think is critical. You can see, just by way of background, that the physician advisor team, we have our hands in a few different pots. And I think if anybody knows anything about quality outcomes and financial outcomes, being a part of what goes on in the appeal space, what goes on in the utilization review space and patient status, and what that means for whether things are counted in your metrics or excluded in metrics, whether documentation is helpful for those cases or not helpful, all those things interplay very much, and it's a very dynamic sort of situation. And I think having that knowledge base all in one house and one shop is critically important as we look to, execute on our mission, vision, and values. So kind of framing what's the opportunity that we had at Intermountain structure historically coverage rate. And what that means is that our CDI nurses that are looking at accounts and looking at hospital stays, we're only able to touch about 45% of the inpatient stays that come into our hospitals. Our staffing model is very lean. We would love for it to be, heftier, if you will, and have more coverage. But as circumstances would dictate, as I think we all know across the country, there's just staffing challenges that exist. And so having technology at our fingertips is one of the ways that we've tried to figure out how to overcome some of those gaps. And so you can see, by and large, most of our attention, as you can imagine, goes to our trauma facilities. It goes to those big facilities where, by and large, we have the sicker, more complicated patients. What that means is some of our critical access and rural facilities are not getting the CDI sort of coverage lens, what have you, that we would like and that they would like. And so having this computer or this CAPD or computer assisted physician documentation technology allows us to have some CDI impact at these smaller facilities that we otherwise would not have. And so this is we'll talk a little bit about the journey of how we implemented that over the course of a couple years' time. And then really, how did we demonstrate some of the metrics, both from a provider engagement with the EHR experience that Sydney can kind of talk about the methodology, and we'll share a little bit of the results, but also how did we capitalize on that to make sure that our financial outcomes were still sound, that we were still getting the quality and safety outcomes that we still expected. So some of the challenges as we look to figure out how we could leverage this technology to fill in some of those staffing gaps and voids that I mentioned, we still struggled with query response rates. And I know if you look around a lot of the chitter chatter, if you will, the LinkedIns, what have you, of the worlds where there's a lot of things going on around documentation and what's the right model for CDI teams and things like that. Are queries the right way to go about, getting answers and engagement from physicians? I think the day maybe down the road will come when maybe we don't have to do those sorts of things. But I think that day is not today, and it's probably not tomorrow. And so we still have to figure out how can we get our physicians engaged in doing a lot of this work proactively as best we can, but merge that or marry that with a process on the back end that still helps fill in some of the gaps that we know are still going to continue to exist with that query process. And so we needed to figure out how to improve some of our query response rates. We needed to enhance our ability to get reports and analytics out there to our physicians so that they understood where the gaps were. They understood how they were being measured. I think the why behind documentation is critically important to physicians as we look to get them more engaged. We can throw all the fancy tools we want at them if they don't understand why this is important. And I think for most folks in this space, you'll not be shocked to realize that a lot of the physicians that we think should understand these things do not understand a lot of these things. While it seems, second nature to us living in the space day to day, so many of your frontline providers do not understand who is measuring them and why. And so getting to that why and then helping them understand, here's the why, here's why we're bugging you, if you will, and here's how we're going to help you do it. That's the critical thing. So part of getting to that why is getting leadership engagement. Having support from the top line leaders and then trickling that down has been critically important to us and our success. I can tell you that about 6 or 7 years ago, when Intermountain added to one of their system KPIs, it was our quality outcomes as a whole. And that was tethered directly to the importance of documentation and physician engagement. Having that be an enterprise goal has trickled all the way down through all the physician leadership structures across the enterprise. And it's gotten us a seat at the table in a lot of ways in places we never were able to get a seat at. And so now, instead of having to try to bang down doors to get in and have a conversation, we have people coming to us to have that conversation and asking for that conversation. Again, leveraging these tools has allowed us to get the physicians more engaged in doing this work because we're trying to help them make it easier. We're trying to help them get it done up front. We're trying to save them time in this effort. We've improved some of the workflows as we can touch on. And then, as I mentioned earlier, breaking down those silos, both as us on our side and structurally with our team, as well as with the physician leaders and how we can partner together in this work and have it not just be so disparate and so separated with us just going to them, telling them we need them to do something, not understanding why, and not really partnering together in that work. So, as one of the solutions that we looked at was with the computer-assisted physician documentation tool. And this has been a partnership that we've had at Intermountain with Solventum for many years now. We initially rolled this out as a pilot in 2020. And if that sounds like a year that has some meaning or connotation to it, it's because it does. That was the year of COVID, as we all remember. And despite the issues with the pandemic, we still were able to roll this out and implement this across the bulk of our facilities of that legacy organization. And we did a couple of things to really try to make sure that we had success in doing this. I think a few key things are important. Number one is starting small, right? Not trying to boil the ocean, not trying to eat the whole elephant in one bite, but just picking a couple, 2 or 3, 4 documentation opportunities for your physician teams to improve on, and really going after that low-hanging fruit. What are the things they should be getting right all the time, right? The acuity, the type of heart failure. That's a very common query opportunity. Our physicians should be getting that right most of the time anymore these days, yet they still struggle. So is there something we can help them with to get this done up front? That's where the CAPD tool comes into play. I think having a test group of physicians that you can kind of use as your guinea pigs, if you will, to make sure that things are functioning and operating appropriately when you roll things out, that they can give you feedback and then you can make tweaks before you roll it out to the masses. Sometimes with technology implementation, you only get one shot to kind of make that first impression. And if it doesn't go well, it's really hard to kind of harness, bring it back and then relaunch and get people to be on board and to be engaged. The other thing I think is leveraging your data. Again, both internally to know what are the opportunities, and then as you go to your physicians and really showing them, hey, here's what the opportunity is, and then circling back with them after some time to show them, here's what using the tools is doing for you. Here's how it's improving your experience. Here's how it's improving the experience for your patients. Here's how it's improving the outcomes for the organization. I think those are some of the three key things that have been very, very helpful in us in being able to roll out this tool and make it a better experience for our providers. And again, ultimately, what we would say is make it a better experience for our patients. With that, I'll turn it over to Sydney to go over some of the methodology, and then we'll talk about some of the results that we've seen with our case study.
Excellent. Thank you so much, Dr. Anderson. My name is Sydney Tate. I am an Insights Director with the KLAS Arch Collaborative. So for anyone who isn't familiar, the KLAS Arch Collaborative is a clinician-led effort to really unlock the potential of EHRs and technology in revolutionizing patient care through standardized surveys and benchmarking. So I've had the privilege to work with both the Intermountain Health team and with the Solventum teams as part of the Arch Collaborative as we all work together really towards that high physician satisfaction with the EHR. So at the core of this, to give a baseline for the results that Dr. Anderson is going to share, organizations in the Arch Collaborative join to measure their clinicians' experience with the EHR. So they administer these surveys that typically take 10 to 11 minutes to complete, understanding the ins and outs of clinicians' experience with the EHR, the technology itself, whether it's functioning as they hope it would, what their pain points are with it, and if they're getting the support they need around the EHR as well. Organizations take that benchmark data, really try to understand the key areas where they can improve, and then leverage best practices and collaboration as part of the Arch Collaborative to really drive the experience forward for their clinicians. Now for these results, Intermountain Health, after rolling out Solventum CDI Engage 1, they measured the experience of their clinicians. And this was a system-wide measurement, understanding really how well the EHR was driving great patient care for clinicians. After they administered that survey, we worked with the Intermountain Health and the Solventum teams to identify which physicians and APPs were using CDI Engage 1 at the time of the survey, and then limiting the scope to others that weren't using CDI Engage 1 at the time of the survey, but that were in the same specialties. We compared those using the solution to those not to really understand the difference of the experience between the two groups when we're looking at things like the amount of time it takes them to document, how much time they were spending outside of working hours documenting, and then perceived efficiency and whether the EHR was really able to enable their ability to deliver great patient care. And I'll just note, as Dr. Anderson shares this, the reason why we on the Arch Collaborative team are so excited about these results is because across all these measurements that happen year over year, it's no surprise that the most common complaints that come up from physicians and the opportunities for improvement are all around efficiency and the documentation burden that they feel. So to get to see this area where Intermountain has driven improvements with both of those through this partnership with Solventum was really exciting for us. So with that, I'll turn it back over to you, Dr. Anderson, to dive right into the results.
Perfect. Thanks, Sydney. And I probably should just, maybe expound a little bit on what the CAP technology or the CDI Engage 1 product was designed to do, right? So the idea is that historically, from a CDI perspective, you have physicians doing their documentation, you have them putting diagnoses in the medical record. Oftentimes they lack specificity, they may lack clinical validation or support, or there may be questions around that. And then you have CDI nurses who are reviewing these cases and determining their an appropriate opportunity here to ask a question to the physician or to get more specificity around a particular diagnosis, to, modified coding, which then may impact reimbursement. It may impact risk adjustment, things like that. And again, that is a model that we still use within Intermountain. But what the CAPD technology is designed to do is it's designed to be an at-the-elbow sort of technology or helper to the clinician as they're doing their note in real time, with the idea being that we have, for example, for our hospitalist group, say, we have picked 4 or 5 diagnoses that we believe, based on our data, are the biggest opportunities for us to improve on, that for whatever reason, our physicians just always seem to lack specificity in their notes around these conditions. As I mentioned, heart failure is one, chronic kidney disease, it may be another one, encephalopathy, for example. What this technology is doing is it's reading over the entire medical record of that encounter to see if there are things that I have missed, or if there are things that could be of benefit to me as the physician as I'm doing my documentation. Did I just, for example, did I just diagnose heart failure and say nothing more? It can then in real time nudge me, not in a way that stops me permanently. It doesn't prohibit me from continuing to do my work, but I'm able to see that, and it's able to just ask me in a way that's compliant, hey, is there more specificity that could go for this diagnosis rather than just heart failure? And again, the light bulb can then go off in my head and go, oh yes, I've been talked to about this. I can, in my H&P, go in and add acute on chronic systolic heart failure to my H&P that will now carry forward and now has the specificity of the diagnosis that that patient carries with them. That's really the idea behind these nudges and what we're trying to do with our physicians. That whole interaction or engagement with the technology tool takes maybe 20 seconds, 30 seconds at the most. And so it can save a lot of time, and hopefully in some ways can mitigate some of these recurrent queries that we have to send to our physicians, which can take a lot of time, get lost, things like that, and all the bugaboos that we know exist with that process sometimes. So with that as kind of an overview of just what the tool is designed to do for our clinicians, here are some of the results that we've seen with the survey that Sydney mentioned. You can see that just in terms of getting inpatient charting completed during or immediately after the rounding time, in the Engage 1 or the Solventum group, it's a 22% improvement in that result with our providers that were surveyed versus those that did not have the Solventum tool to be able to be used. Now, again, I'll say with this metric as well as the other metrics, have we climbed the hill and reached the summit? No. Are there things that you're going to see that still say, hey, there's opportunity to continue to improve? Absolutely. But I think if nothing else, this data shows us that we're moving in the right direction, right? There's more work to be done, but we're moving in the right direction of trying to improve that experience for our providers. You can see that in terms of any time outside of scheduled work hours, how quickly are they able to complete that charting, and in what amount of time has that taken? You can see that it's 39% less than 30 minutes outside of scheduled work hours. But even if you extend that to an hour, over 50% of our providers were spending less than an hour outside of work time completing their charting. Now, you could say ideally we should not have to be having any hours outside of work time. And for sure, that is the ideal situation. But again, I don't think we can lose the sight of progress for the pursuit of perfection, right? Like it's going to take time and iterations that we tried to get this. But you can see, compared that to the non-Solventum group, even if we take that out to an hour, it was only about 30% that were getting things done in less than an hour outside of scheduled work time. When you look at the overall EHR experience score, again, neither one of these scores is awesome, and we would love to celebrate, but I think what it tells us is we're at least moving things in the right direction with this. And I think, as we know, there are a lot of things that go into what is going to drive someone's rating of an EHR. There are a lot of factors. There's not one sole factor, one sole tool that's going to probably drive that. And so this clearly shows there's a lot more work to be done. But are we chipping away at some of the issues and some of the negative experience? Yes, I think that's what the data reflects. And then you can see a few of the other metric points or data points that were measured here. Did this enable efficiency? Again, starting to get there. Are there then things maybe we could circle back and optimize or improve or enhance? For sure. Is it enabling quality care? Again, in a market improvement between the Solventum group and the non-Solventum group. And then does this enable patient safety? Again, an improvement in the Solventum group to the non-Solventum group. Finally, the EHR vendor has designed a high quality EHR. As I said before, I think this incorporates a lot of factors, not just whether the Solventum tool is the sole thing being rated or not, but having that tool partnered with the EHR was making it a better quality EHR than where we started. Personal accountability, again, I think having this at the elbow of the physicians, having a technology tool that just kind of, as I said, nudges them, not in a way that's overly interruptive, not in a way that prohibits them from moving forward if they just don't have time at that moment, but it allows them to kind of have ownership of getting those things done on their own, rather than that pure chase model of a CDI nurse sending a query, chasing docs down the hall, as we all remember, we're kind of waving the paper to get something signed or filled out. And then overall, does the organization IT deliver well? There's not a huge difference here. And again, I think there's multiple factors that can drive that, but we certainly held steady. We did not go backwards by using the Engage One tool with the EHR that it was partnered with. So I think those are essentially kind of the results of how this project, this case study has worked. There's a lot more that could be said, I think, about that. When you look at some other metrics outside of what the KLAS study actually measured, but when you look at things like the number of diagnoses that we were able to add compliantly to the claim, hundreds of diagnoses, the number that were CCs or MCCs, that again, if folks are familiar with some of the reimbursement DRG models, CCs and MCCs are critically important in some, in that reimbursement model. Were we able to improve our risk of mortality and severity of illness scores? Yes. Our CMI scores went up. Our expected mortality scores went up. Our capture of HCCs, a different reimbursement model, went up. Our capture of Elixhauser conditions went up. So again, all in all, when you look at all of the different things that are important to us as an organization, using this tool as an augment to the foundation of good people, educating our providers, helping them understand the why, how to do some of this, and then leveraging technology to fill in that gap has been critically important to our mission at Intermountain and has given us tremendous results in both the financial and quality space. And I think it's helped improve the overall documentation for our patients, which ultimately I think is the true north of having a complete and accurate medical record, telling that accurate story that is immensely important as our patients move across the healthcare continuum through different providers and different clinics and different spaces, so that we know the right things to do for our patients at the right time and in the right place. So with that, Travis, I'll kick it back to you and do some Q&A.
Sure. Yeah, that's perfect. Thank you both for sharing. And I think one of the main things that will motivate a clinician is when they're being measured by, for their performance. And I think this is something that this is the only way to prove to clinicians and to prove to organizational leaders that using a technology like this is actually benefiting them. And you got to show them outcomes and report it back to them. And so I think that's one of the change management pieces that you do so well. So you're measuring, and you're then taking that and putting that in front of physicians to say, look, this is what your documentation is actually showing, and this is then a reflection of the performance of your service line and of the organization. And so the change management part is something I want to keep going with, because you mentioned this several times, and you mentioned getting to the why for physicians. And so one of the main pieces of change management frameworks is desire. And so understanding for clinicians, what's in it for me? And I think that that's something that's just kind of like a human nature thing, but I think you've kind of naturally done this very well at Intermountain. And I've heard you talk in various settings about how you've got you mentioned having physician testers for this type of technology, but also physician messengers to actually talk about, hey, this is what's coming. This is the rollout, whether it's a geographic hospital location or a service line or what have you. You have physician leaders that are ready and able to talk about it because you've included them obviously in the kind of prep for deploying such technology. So can you talk a little bit more about, I mean, is this something like you naturally understood? I mean, because this is how you would want to be treated, or what was the thought process that you and the team went through when thinking about, all right, if we're going to roll this out across a large organization, we really need to kind of prepare our clinical leaders and our staff well before we just like flip the switch to turn it on?
Yeah, it's a great question. And I think, over the years, if anywhere you go to, any conference, any forum where you talk with colleagues around the country who are in the CDI space, quality space, one of the key questions that always comes up is, how do you get your physicians engaged? How do you get your physicians engaged? Everybody wants to know that. And I will not sit here and say that we've solved that Rubik's Cube and that we have all the answers. I mean, we still have some of the engagement issues with some of the specialties that most people can imagine and are familiar with. But what I will say is, as I mentioned, about 6 or 7 years ago, when we kind of organization, that really started to set the tone. As I mentioned, that then got down to our physician leaders who are now being held accountable for certain outcomes around quality and safety metrics. As things have changed over the last couple of years, obviously the finances have become ever more important. Not that they weren't important, but they are, as important as they've ever been, I guess I would say at this point. Those leaders now feel the same pressure to have financial impact and outcomes as well. And as they start to ask the questions, how are these things tabulated? How do we impact these things? Things that we've understood for years now start to come to the forefront in their minds, and they start to realize documentation is at the heart of a lot of this stuff. I think it's as I mentioned, it's an assumption that I think a lot of our clinicians have, is that if I just do good quality clinical work, that gets represented, right? Everybody's going to know that. It's going to be seen in the billing. It's going to be seen in the notes. And I think what we quickly realize is that is not the case. In a lot of ways, there is exceptional quality work taking place, but our physicians in a lot of places are not accurately documenting that. And therefore, it is not being represented in the way that we want it represented. And so you have to figure out a way of how you get the message to those clinicians. And I think getting an audience with them and getting them willing to listen to somebody is a challenge. And I can say within the Intermountain scope, historically, there was a time we used a lot of the contractors, the vendors, the consultants that exist out there in this space. And we just never got any traction with that. And so as part of our physician advisor program and structure, one of the arms that we added about 7 years ago was what we call physician educator arm. Some places may call it a CDI champion. I mean, there's different labels or titles for it. But the idea behind this was we have a couple of docs on our physician advisor team that are geographically spaced out across our organization, working in these trauma facilities. And we kind of use a hub and spoke model where the trauma center is kind of the hub, and then our smaller facilities in that surrounding area are the spokes. And these physician educators, they're part-time. They're still doing clinical work in those facilities. So they have relationships with those physicians that they are then going to be talking with and educating with. There's a kind of a natural born agreement already to have some collegiality and some, respect already born in there, that if you bring in an outside contractor, it doesn't exist, right? It's just somebody from somewhere who's going to, pick up and take off, and we may never see them again. Whereas these folks we see every day in the hallways, we see them in the doctor's lounge. And so we created this model where these physicians are now our CDI champions. They understand risk adjustment. They understand quality metrics. They understand what the technology tool can do for these physicians. They're the ones that go out and work with the hospital leaders and then the teams of those hospital leaders to educate them and talk to them about this work, about the why. And it requires a lot of elbow grease. It requires a lot of work. It's not a quick endeavor. It took us a lot of time to kind of get that level set where we could get this education disseminated out across the organization. But it can be done. And I think it's necessary if you really want to have, again, we don't have perfect engagement, but if you want to have 75% better engagement, you've got to merge this idea of education, relationships, physician to physician interaction with the technology tools that can then support them in doing the work.
Yeah, I think that the culture piece, I think, is sometimes seen as such like a soft thing, but you could really fall flat if you're not thinking about that. And so I'd like, thinking about folks, stakeholders that speak the same language, going out and delivering the message. The messenger is sometimes just as important, if not more important, than the message itself that they're carrying. So I appreciate how you frame that. I think one of the other things you mentioned is quality outcomes and quality measurement, and how those expected values for some quality measurements come from documentation. And so I think physicians are more and more getting dialed into the fact that, hey, the way I'm measured by external entities, or that the way my quality is measured or performance is measured, has to do partially with my documentation. And so can you talk a little bit more about how your accomplishments in those areas, I guess, about how you mentioned this already kind of a little bit, but how you've impacted those quality benchmarks in your analytics platforms, and maybe how you've kind of used this data to circle back to show your physicians and help keep them engaged, and say, look, like what you're doing is working.
Your organization has to pick their true north of how they're measured, right? And there's different entities and benchmarking platforms out there to do that. And other organizations may use somebody different, but you have to pick that to start with and say, this is our true north. I think once we did that and we kind of had a framework around that, then we could start to get data. And I think you have to spend a little bit of time about making sure that the data, as accurately as you can get it, knowing that sometimes in the hospital space, it's challenging because it really is a teamwork environment, right? You have multiple hospitalists coming on and off shift. You then have surgeons. It can be really hard to figure out attribution sometimes with data, and it really is a team sport. So there are some ways that you can come up that are creative to kind of figure out, how do we get a rough ballpark attribution of the data? And then I think you got to go and share that data. I think what we found historically is a lot of times when you would show group data, and if it wasn't very good, I know in my hospitalist group, every hospitalist would just look at their neighbor and go, well, it isn't me. It's got to be my partner over there. They're the one not doing it very well, right? And so we actually worked with a lot of leaders to unblind a lot of the data. And again, it's not in a punitive way. It's not to say that anybody is a bad clinician, but unless you understand where you truly are at in the measurement, there's nothing, you can't begin to do anything about it. And so having that data at the group level, but then taking it down to the provider level, really was critical to be able to open some eyes and get people to say, oh man, maybe it is me, and I don't want to be at the bottom of that list. I want to be at the top of that list, right? Nobody wants to be at the bottom. I think by and large, most people show up to work to do a good job and to do their best and have good outcomes. So once we got to that point, now you can start to have the conversation of, well, how do I improve this? Because if people see they're not doing well, naturally the next question is, how do I improve that? And that's where I think, again, some of this could be clinical, right? I mean, if you're not giving antibiotics to the septic patient, that's a problem. That might be, issue number one to rectify. But once we can look at it and go, look, from a clinical perspective, it looks like the right things are being done here. A lot of the gap is you're not telling the story accurately and correctly in the medical record. That's the conversation that we can now have. And then we can start to work with those providers on what they can do to improve it. And what are some of the technology tools like the nudges that can help them in improving some of that? And I will say one of the cool things about the Engage One tool is that there's a kind of a natural learning functionality to it, whereas clinicians kind of get nudged about heart failure. After 3 or 4 times and you've seen that nudge, most people, the light bulb goes off and you start to say, hey, I need to make sure I put the specificity in there so I'm not getting nudged. You can kind of measure that natural learning ability. We have the ability to see, oh, they're now just getting it right out the gate. They don't even have to be nudged about this diagnosis anymore. Great. What's the next opportunity that we can help them with, and we can move on, we can continue to build on that and reiterate things. So
no, I think that these are fantastic points, and I think just the fact that you're addressing it with kind of almost this adult learning theory or models, the fact that you need to kind of put targeted pieces in the right places and be thoughtful about how people are going to actually embrace that and learn from that. And then, yeah, showing the data. I think there's always been concerns about unblinding the data and putting that out there. But if you demonstrate you're using it for purposes of getting folks engaged, and you've got the tools to support them in improving their measurements, I think people can get on board with that much quicker. So one more for me. One of the things you all have done with CDI Engage 1 is to really help to address issues and use some of the natural language understanding evidence sheets to address issues around end-of-life care. And I think some people may not think about hospice or palliative care as a target population or a target kind of service to use this type of technology. So could you tell us a little bit more about what you have done in that space?
Yeah, so I think one of the cool things that's come out of kind of our partnership with the Solventum folks is we have been given some liberty, if you will, to be able to figure out how to be innovative and creative with the NLU technology. And probably like a lot of organizations around the country looking at our quality metrics, mortality is always one of those that kind of can stand out at times. And in most of the benchmarking platforms, it's heavily weighted, right? I mean, it as it should be. And we, in a lot of places, and especially early on kind of in this work 6-7 years ago, we had a huge opportunity in our mortality work. Certainly in the documentation side, that expected piece and that O to E or observed to expected ratio equation, but we had a lot of opportunity in the observed side of things, or the actual patient deaths. And certainly, as I mentioned, you always want to address the clinical care. Are we using the right, modalities and interventions for, door to balloon time and door to CT time? Are we doing all of those things correctly? But once we are there other things that maybe the data are highlighting for us are opportunities? And one of the things that we identified was clearly there was an opportunity to enhance or improve the end-of-life experience for patients that we knew were going to expire. And we saw a lot of patients in the hospital at times for days, and we could see where this was going in the trajectory. But there were a lot of struggles and just, again, some of the fragmentation between the different teams and who was seeing what and who should connect or not connect, that we were oftentimes not involving our end-of-life teams until the midnight hour, which is really suboptimal in most cases. It's a hard time for families. Obviously, it's a hard time for the patient. And now you're talking to them about, is hospice appropriate? Here, sign this form and fill out this. It was not a huge satisfier. And so what we wanted to do is, how could we identify some of these patients earlier upstream, have our care managers, have our frontline physician teams, our nurses, and our end-of-life teams be connected earlier, so that if and when things went the way we thought they were, everything was in place. We'd already had the conversations, and we could set that patient and family up for the best end-of-life experience that you could have, given the struggles of that time. And so we created our own version of nudges for our end-of-life patients, where, again, it funnels into a work queue for our care managers each day. It's looking at certain terms and verbiage in the medical record of our patients in the hospital that just may indicate things are not going well from a clinical standpoint, that they may be approaching end of life. It nudges our care managers to say, hey, I should prioritize that patient and go look and talk with the clinician to see, do they have the services they need? Are they having the conversations they need to? What can we do to support? It's not forcing anybody onto a hospice, team. It's not forcing any clinician to do anything. It's purely raising the awareness so that the right teams get connected and we can hopefully get our patients the right care. And I can tell you that has helped our patients and our experience. And I've heard numerous encounters where patients and families have had a great experience by getting our end-of-life teams involved sooner. And, again, secondary probably, but now certainly important, our mortality metrics have dramatically improved. as we've leveraged this technology to better identify folks who ultimately could benefit from end-of-life services much earlier, and how that then translates into our mortality metrics. So
yeah, no, that's fantastic. Thank you. No, thank you for sharing that. And I think that the documentation capture, I think sometimes people get so focused on documentation and it's like, well, why are we doing this? And I think there's just multiple angles towards, if you are capturing more completely and accurately health information around this single patient, it can drive care processes, it can drive quality measurement, it can drive reimbursement in a fee-for-service or in a value-based world. I mean, just this complete capture of the picture can drive multiple things. And I think the more that physicians, clinicians see this, the more organizations see this, they kind of understand, okay, wow, you know, complete and accurate and compliant capture is really critical, important, beyond just reliable health information around our population. So thank you for sharing that. Bree, I don't know if we have any questions that have come through, if you want to kind of end with questions from attendees.
We do. We have a few questions in the chat around nudges. Dr. Anderson, you talked about nudges that you've enabled, specifically this last example for end-of-life care, and you touched briefly on the specificity and acuity of heart failure. What data do you look at to decide which nudges to be enabled? And can you share some examples of those?
Sure. So we look at, again, knowing just that at times it feels like you're asked to kind of serve a couple masters at the same time, right? Whether it's the financial folks or whether it's the quality folks. But we look at one, in terms of finances, like our CC and MCC capture rate, and we can see what diagnoses that fall under each of those categories, where we are maybe not benchmarking to our peers in the same degree of capture rate. And so those are opportunities that we can identify and maybe go and work with our clinicians to say, hey, you know, this may be an opportunity. The other is that we look at our quality safety benchmarking platform. And in there, we can also look at where are the documentation capture opportunities that, compared to our peers who are like us, we're not capturing the same amount of diagnoses that they are. And there may be reasons for that, right? I mean, geographically, perhaps where we are at, there's not as much sickle cell, right? Because of our population versus somewhere else. But by and large, that's an indicator to us that there's perhaps something that we're missing, there's specificity that we're not capturing, or there's just overall education gaps that we need to fill in for our providers so that they're aware. What we did is, because the data, for example, for our hospitalists in those buckets may look different than the data for our cardiologists, we've built different service lines and different nudges for those service lines based on the data for each of those specialties. And that, again, it takes a little bit of work. It takes some time. It's not an out-of-the-box sort of thing. But we've configured the nudges for our hospitalists to be based on their data and what will help them get the most bang for the buck and improvement. And we've also configured something similar for our cardiologists, for example, so that they're getting bang for the buck in what's the opportunity in their data, because they're not always the same. And you could say that about neurosurgeons or your general surgeons or, you know, intensivists, whoever. So we have about 8 different kind of service line configurations that we have different nudges turned on for those different service lines based on what those different data areas are showing. And again, some of the top ones, like I said, we try to hit the, like I said, the term is the low-hanging fruit, right? What are the ones the doc should be getting without a lot of thought? We don't turn on nudges that are super complicated. Like sepsis is not a nudge that we have turned on. There's a lot of, obviously, as most people know, debate, controversy. Maybe you think it's consensus, I don't know, around what's the definition of sepsis, and then what are the implications in terms of, you know, PSIs and other quality metrics. We don't want docs being nudged and kind of just sort of, you know, in moments of haste or that, documenting sepsis around a nudge. So we really try to keep it to those low-hanging fruit, sort of easy, straightforward things like heart failure, stage of chronic kidney disease, type of encephalopathy, you know, those sorts of things.
Definitely not lacking in customization for nudges, that's for sure.
Yes.
Okay, well, we are at the end of our Q&A. Thank you so much to our speakers and to everyone that's joined. Once the recording has processed, it's going to be available on our website. If you have follow-up questions about Solventum CAPD or CDI Engage 1, please connect with your account rep, reach out to us through the link through the webinar platform, or use the contact us form on our website, and we will get back to you. Thanks again.